Hello, everybody. Thank you for joining us. Love to see that people remain afraid of the front row, even as we get older. I'm the same. I show up to things early and I take the back row, so I'm not here to judge you. My name is Becca Hibbert. I am the Director of Sports Medicine here at Spooner, and thank you for joining us in person. I think this is maybe the most people we've had in person, so sorry for those who ended up on rolly chairs, but we appreciate you being flexible. If you need to get up and kind of walk around, obviously, we all know sometimes we want to get up and move, so by all means do that. But our program is pretty short today, so I'm very excited to get started. We are going to talk about concussions, return to sport and school today. Obviously, a topic that remains a hot topic in sports medicine. It's always changing, so I'm very excited for our speakers who are going to talk to us about some of the most up-to-date things that have come up around concussions in recent months and recent years. I do want to let you all know that we are hosting another Con Ed course in November, completely different from this. It's called our Functional Golf System. There's flyers on the back, and we'll have more information in the email that you'll get from us post-event. This is a system or an educational course that helps take care of the golf athlete from head to toe. It's all about biomechanics, making sure that we know how to best help those golfers function. If that is the type of athlete you love working with, I would highly suggest the program. So like I said, there's flyers on the back there. Feel free to check out more information, and we'd love if you were able to sign up. It will be in November. How today is going to go. Both of our speakers will come up here and talk for about 30 minutes, and then we'll do a Q&A. We would love if you have questions in person. Go ahead, raise your hand. Otherwise, I have a list of questions that people have sent in because I know sometimes the crowd needs to get warmed up a little bit there. So without further ado, I'm going to go ahead and introduce our first speaker, Dr. Jennifer Gately. Dr. Gately is from Michigan and earned her medical degree from Wayne State University in Detroit. After medical school, she completed a pediatric residency and primary care sports medicine fellowship at Rainbow Babies and Children's Hospital in Cleveland. She has been a team physician for high schools and colleges and provided medical coverage for the Cleveland Marathon, the Cleveland Triathlon, and statewide youth soccer tournaments. She enjoys working with children and teenagers to get them back into activities they love. Please welcome Dr. Jen Gately.
Hello, everyone. I'm Jen Gately. So we're going to talk a bit about sport-related concussions, as you know, and I'm really interested to hear what questions you guys have after, what you find are sticking points, like whether you're an athletic trainer, physical therapist, just so we can work through some of the hard parts about caring for athletes with a concussion. So there are 4 primary things I want to talk about today. The first of which is how can we predict recovery in athletes from their concussion? Because this is a big question that we get in clinic. When am I going to feel better? When am I going to get cleared? So what types of things do we see that help us determine that outcome? And then talk about what is the best return to learn strategy. Personally, I find this is the biggest sticking point when I see people in clinic. So I think coming up with a good plan there and troubleshooting when issues arise is really important. We'll talk about returning athletes to general activity and then sport-specific return as well. And Lauren will cover more of that. And then we're also going to talk a bit about concussion prevention at the end because we get a lot of questions about that as well, which I'm sure you guys do too. And then I think we're doing the Q&A at the end, right? Okay. So first we're going to talk about predicting recovery. And before we can really talk about recovery, we want to make sure that we have the correct diagnosis. And I am sure that you guys are all great at diagnosing concussions. A lot of times we can just hear the history and kind of know that somebody has a sport-related concussion. But occasionally I will see people in clinic where, let's say, they play soccer and they have a game on Friday, but on Wednesday they get a headache. So then they come to me for a concussion evaluation, even though there was no inciting injury, no other issues. They were fine until this Wednesday. So one of my partners will say, make the story make sense, essentially. So with a concussion, you really need an inciting event or some suspected inciting event. So generally, we consider a concussion from a direct blow to the head, neck, or body that will transmit forces up to the brain. For our standpoint, it's going to occur during sport or exercise-related activities, and then those symptoms should come on relatively quickly, so within minutes to hours after the injury. And then generally, we're not going to see any acute abnormalities on imaging like a CT or an MRI. One caveat to the symptom development is high school football. I find that sometimes kids will play on Friday night, get an injury, but then they don't really do anything over the weekend until they go back to school on Monday. And then on Monday when they're in class, they'll notice, okay, I have a headache, I feel nauseous. So then you have to think back to Friday, do we think anything might have happened there? So just one thing to keep in mind. And then we also want to talk about how we define recovery, and you want to think about this when you're reading articles as well. So you can talk about symptom resolution at rest, you can talk about a full return to learning with no new academic support, or you can talk about a full return to physical activity or sport with no symptom recurrence with maximal exertion. So when we talk to patients in clinic, or when you guys do probably as well, generally I'll tell them that most patients are going to recover within a 4-week time frame. That's basically for all ages, but it's very variable. So some kids are going to feel better 1 week after the injury, but I will have other kids who take months and months. So it's the ones you think are going to be beyond that 4-week period or who have persisting symptoms that we want to try to identify to see how we can help them. And then one of the most important things is to discuss the expected recovery with families, because a lot of times after the initial visit, even if they have a high symptom burden, they'll say, okay, well, when I come back for the follow-up next week, I'm going to get cleared, right? So managing that expectation that, no, you have to be symptom-free before you can go back to contact activity is really important, even if you can start other activity before then. So probably your best predictor of a prolonged recovery or persisting concussion symptoms is going to be a high initial symptom burden. So your symptom score at the time of the concussion or the injury and then immediately afterwards is going to be the greatest tool that we have to say, okay, it may take you more than 4 weeks to recover. Additionally, people who continue to play for a while after their injury are going to be at higher risk for a prolonged recovery. They've shown also that if there's delayed presentation to a medical provider, that can prolong your recovery as well. So sometimes, like if there's not an athletic trainer on the sidelines, you don't get pulled when you have a head injury, so you continue to participate, and then you don't know at which point you should seek medical care. And then migraine headache history in females may increase your risk for a prolonged recovery as well. Other things too, and these two are kind of hard because prolonged cognitive rest, so not doing anything for a long time, can potentially contribute to persistent symptoms, but so can a really high level of cognitive activity right after the injury. So we kind of have to balance how we take them back into school, work, things like that, based off of their symptoms. Athletes who participate in individual sports, I'd be interested if anyone has read this article or anecdotally has noticed this. I just read this recently. There was a study done looking at Division I NCAA athletes and concussions, and they found when they compared team sport athletes to individual sport athletes, those who participated in an individual sport were more likely to take longer than 4 weeks to recover. So that would be like gymnastics, dance, cross country, things like that. And then sleep disturbance in the first 10 days after the injury will also contribute to persistent symptoms. So sleep, I broke out a little bit because we see a lot of sleep issues, especially in clinic after the concussion. So generally, I feel like kids will sleep a lot during the day. They'll sleep a lot at night, and then they wind up sort of backing up their entire sleep schedule, and that affects their recovery and their symptoms when they then try to go back to school. So these are the most common kind of complaints that you'll hear from them sleep-wise, but what we generally talk about in clinic is really like general sleep hygiene. I want them to try not to take daytime naps if possible, and we say, I would rather you sleep extra at night versus taking a 5-hour nap in the afternoon and then sleeping 5 hours at night, getting up the next day, going to school, and doing it again. One caveat to that is if you're already a napper, like I myself am, I will say you can still take your normal naps, just don't let them be super long. Increasing exercise can help as well, and we'll get to that later. And then if they're really having a hard time, you can consider melatonin as well. I would ask people about that. A decent amount of athletes I see are already on melatonin. So this is just a brief slide, and you guys are a lot of therapists and trainers, so you probably already know when you want to see referrals. But from our last concussion consensus statement, really if any athlete has more than 10 days of those 3 symptoms, so dizziness, neck pain, headache, we're instructed to refer for cervicovestibular therapy at that point. Usually, it's hard because we expect a 4-week recovery period. So if I see someone at 10 days and let's say they still have these symptoms, but overall they're improving and they tell me they're like 85% back to baseline, I will probably hold off on a referral at that point. But if they've plateaued or they feel like they're getting worse, then I'll put it in then. And then this is just a plug. Our PCH has a multidisciplinary concussion clinic. So for kids who have persistent symptoms or symptoms that don't seem like they're getting better, even within that 4-week period, we can refer for physical, occupational, and speech therapy evaluations, and then they can receive those services. You can also do independent PT clinics as well, as long as there's a therapist who's trained in concussion or vestibular therapy. And our sports physical therapy will see the less complicated concussion patients too. And then we're going to talk a bit about return to learn. So again, like I said, this is the biggest issue I see. So a lot of times, by the time the kids get to us, they've been diagnosed with a concussion, they've seen their primary care provider, and they're told to try to go back to school, usually with accommodations, which is helpful. Then they'll go back to school, get a headache, and then they'll call the pediatrician and they're told, don't go back to school until you get in to see sports medicine. So by the time we see them, it's been 2 weeks of just chilling at home, staring at their parents, watching TV, I don't know. And it's hard to undo some of those things. So I think if we can get it right from the start, it will help our athletes a lot. So generally after like the first 24 or 48 hours, depending on how they're feeling, I encourage kids to go back to school. Some kids feel fine, and then I say, okay, well then let's just try full days, see how you do, but I always write for accommodations just in case they need it. If you see someone who's really symptomatic, then we'll say, okay, should we maybe start with half days or alternating half days where we pick your easiest classes and then we work up from there, whatever it may be. So we have to be a little bit flexible when we talk about the return to learn strategy. These are just some factors listed here that are associated with a delayed return to learn. One thing I would point out is a psychiatric history. So in athletes who have a history of anxiety or depression, a lot of times those symptoms will get worse with their concussion. So we want to make sure we're asking about it and making sure that they're getting the services that are going to benefit them. So do they see a counselor? Do they have a psychologist, a psychiatrist? Are they on medication? All those kinds of things, just so we can support that aspect of the recovery as well. So in the literature, they will say that most athletes of all ages have a full return to learn with no support by day 10. Anecdotally, I do not find that to be the case, if I'm being honest with you, and that may be because I'm just seeing them after that 10-day period as well. Up to about half of athletes will get some sort of academic support, but I give almost everyone some sort of list of accommodations just in case they need it again. And then it's been shown that adequate accommodations will improve their emotional and social health related quality of life scores, so we want to really support them as they get back to school. And then, as you can kind of anticipate, those who have a higher symptom load and severity at the initial visit are usually going to have a harder time getting back into school. So these are just some specific return to learn strategies. Again, kind of what we talked about already. Attending core subjects sometimes we'll do. So what do you need to finish this grade? Or what do you need to graduate? Let's try to attend those classes. And then maybe we use the electives as a study hall, or we skip them, or whatever it may be. Sometimes kids will come back and they'll say, well, I'm feeling really bad, but the school day is okay. And then I go to marching band and then I feel terrible. So making sure to ask about their extracurriculars, if they're in like trauma club or things like that, just to decide, do we think it's helpful to still do those activities, or should we maybe put a pause on them? The other thing I would say about this, and you guys probably see it as well, is one of the things I talk about is I want them to feel as normal as possible, because the longer the symptoms go on, it becomes really hard emotionally because you're not doing the things you want to do. You don't feel like your normal self. So if you can go maybe watch drama class, but you don't do a monologue and you feel okay, that's fine by me, because socially I feel like that's important. And then there are specific workload modifications. So we do a lot of pre-printing of notes, or we try to. We'll get into some of the barriers for return to learn strategies, but anything you can take off of a screen and put on a piece of paper is generally going to be really helpful. If a school says, no, we refuse to print anything for you, then usually what I'll do is put in there, okay, look at a screen for 10 minutes at a time, take a 10-minute break, come back to it, whatever it may be. And that's kind of how I tell them to do their homework as well. So if there are classes they absolutely have to do work in, I say you're not going to be able to come home and work for 3 hours at a time like normal because you don't have the mental capacity to do it while you're recovering. So you want to take everything into small chunks of time. So you work for 20 minutes, take a 10-minute break, and you do that over and over. So everything will take you longer than normal, but the goal is that at the end, you don't feel terrible. And then these are some other accommodations we recommend too. So one other thing I talk to them about a lot is anticipating an increase in symptoms when they go back to school. Because like I said, a lot of times they'll go back, their headache or dizziness or whatever it may be will get worse, and then they won't go back again until they've seen you or they're really scared to go back. So generally I'll tell them, we have to think about it like kind of a little investigation. We try this, and then you pay attention to how you feel in these classes. If your headache gets worse sitting in math, that is not dangerous. That's just information for us. So when you see me again, bring me that information, and then we can change your recommendations according to that. So nothing is set in stone. And then the other thing too is asking if their return to learn plan is actually being followed. Occasionally parents don't know that they're not getting the accommodations we talked about, so just clarifying that is important. Again, you want to know your return to learn audience, and this is something I feel like I've had to learn the hard way a little bit. So you want to know who the recommendations are going to. If I give you an end of visit with all these beautiful things I want you to do and you take it to an athletic trainer, I'm pumped, right? Because I know everybody in the school is going to get it. Chances are it's going to be followed. If you're taking it to a school nurse at a private middle school, I don't always know necessarily what's going to happen. And I don't know how comfortable those people are with implementing the accommodations as well. So making sure that we make it as clear as possible that we need everyone in school to follow this. So figure out the person who can help coordinate that for you and go from there is going to be important. There are different barriers to implementing the strategy. I would say most high schools are good at it, most public high schools, because they're really used to seeing kids with concussions. They have athletic trainers on staff. So I don't see as many issues there, but sometimes kids will go to school and they don't feel comfortable speaking out or saying like, hey, I'm not supposed to take this quiz or I'm not supposed to take this test. So they're doing a lot of extra work we don't want them to do because they're not comfortable saying I'm not supposed to do it. So encouraging them to speak up, or their parents to reach out to the school to remind them, hey, we have these accommodations in place, we really need to follow them, is going to be important as well. And then I've had a lot of high school kids where they sort of just don't follow our plan because they need to take AP tests or final exams. And for those conversations, again, I've had a few where it's tough. It's like their junior year and they want to take an AP test. And if they don't take it now, they have to take it 2 weeks later. And at a certain point, I can give you guidance and I can tell you what I recommend. And I can tell you if you take an AP test, you might feel worse for a while. But at the end of the day, it's up to you, right? What is more stressful, having a headache and being done with it, or just waiting and continue to study until you take it at a later date? So I leave a lot of it up to the families and their comfort level, as long as we're not talking about going back to a contact sport. This I just thought was interesting. It was a survey study they did where they sent this survey to a bunch of public high school principals in Indiana and asked them about their basically comfort level treating concussions and knowing about concussions. And they had a decent amount of respondents, almost 160. Only a third said that they got any training in academic concussion management, which is tough to hear. And then only 22% felt very comfortable, but about 62% were somewhat comfortable with the academic management of the concussion. So I think that's where having an athletic trainer at a school is really helpful, because they are obviously very comfortable with that piece. Additionally, they kind of asked the principals, like, what is your biggest barrier to implementing these strategies? And they said it was a lack of communication, basically with myself, them, the family. So we try to make our recommendations as clear as possible, but I always tell people if there are issues or this isn't working or you're getting a lot of pushback, then certainly call me. I'm happy to talk to any school about it, especially if they have questions about what specific accommodations we're recommending and how they can do those successfully for the students. They're likely to follow some of the recommendations, so the breaks and limited screen time, but a lot of them are unwilling to do accommodations for standardized testing. This is interesting, and I've come across this a few times, and I see a couple head nods, so you guys probably have too. With this, I say, like, my goal and your school's goal are not the same, right? Your school wants you to take a standardized test because they need funding from the state or to prove you're a good student or whatever it may be. But if that test is not affecting your final grade or your ability to go to college, then it's probably not something that we need to do right now, despite what the school is telling you. Obviously, sometimes people leave and they're like, no, I got to take it. And that's fine. But I remind them not everything is maybe as mandatory as it feels in the moment. And then we're going to talk just a little bit about return to activity, because I know Lauren's going to cover a lot of that. But I'll get a lot of questions like, when can I start going back to the gym? When can I play ice hockey again? Of course, that's what the kids care about the most. So it's always the very last thing I talk about so that they have to listen to everything and wait for that moment. So by the time I see them, they're generally way past 24 to 48 hours after their injury. If they haven't been doing any exercise, then we really encourage them to start. So after a day or two, it is safe and it is beneficial to start light aerobic activity. So I'll tell them to go for a neighborhood walk for 15 or 20 minutes, ride a stationary bike, whatever you want to do, as long as it doesn't make you feel worse. A lot of people are nervous and they'll say, okay, well, what if my symptoms get worse? Well, just pay attention to when that happens, right? So if you're on a walk and at 20 minutes you get a headache that seems significant, then next time you go for a walk, go for 15 minutes, and then you build up from there. So a little bit of trial and error, again, with non-contact activity is relatively safe. And then generally they can sort of gradually increase their exercise intensity as tolerated, and we're expecting no more than a mild and brief exacerbation of their symptoms. So in the return to play protocol that came out a couple of years ago, they define this. So it would be no more than 2 points higher on a 0 to 10 point scale for your symptoms, and the symptom increase shouldn't last more than an hour after that activity. This is the return to play protocol. I won't go too in depth, like I said, because Lauren is going to talk about it. One of the things that's a little bit different, though, is they added this step with kind of day-to-day activities as step 1, so symptom-limited activity. And then step 2 is broken down into 2 things, so light activity and moderate activity. And they give heart rate guidelines. You guys work with teens, you know. I think it's tough to say, get out that watch or measure your own heart rate. When you're at 55%, let's keep it there. So I think from a real world application of this, I would still recommend more just go based off of your symptoms than your heart rate. If you're someone who's doing the Letty protocol or the Buffalo concussion treadmill protocol, yes, use that data because you have it essentially. But if you are a normal kid not getting that, I don't think that you have to be measuring your heart rate. The other thing, too, is you can start individual sport-specific exercise, but they say that if there's a risk of head impact, then you should get medical clearance beforehand. And then these are steps 4 through 6. So this is more kind of what we're used to seeing, like the non-contact practice, full contact practice, and then totally back to sport. If they've had baseline testing, like an impact, a SCOT, SCAT, whatever it may be, usually I'll have them repeat it before step 5 and make sure that they pass before they go to that full contact practice. And again, this just kind of outlines the brief, mild symptom increase. So now we're going to talk a little bit about concussion prevention, and I get a lot of questions about this, not from football though, it's from soccer parents. I'm not sure if people see the same. I get a ton of questions about headgear. There was a good study that came out, the article is down there, about helmets as a potentially protective equipment. We know they help against things like skull fractures, brain bleeds, all that, but we cannot say if you put this helmet on, you will not get a concussion. There has been some evidence that thicker padding over, I put this picture in this morning, here and here, may help reduce the rate of a sports-related concussion in football, and then a secure helmet fit may help as well. A lot of that, I guess, might be intuitive to think about. If you are an athletic trainer or an equipment manager, things like that, a lot of times parents will say, what helmet should I buy? What's the best one on the market? And there is a website here. I don't know if you guys have seen this before, the Virginia Tech Helmet Ratings website. It's basically a lab. And so they test a bunch of different helmets and they rate them. And if you go on their website, they'll tell you what their testing protocol is, how they give them their rating. And they have it for different sports too. So they have it for youth football, varsity football, ice hockey, bicycling, a ton of different things. So if somebody says, no, I want you to tell me what to buy, this might be a good resource to use. So this is an example of the varsity football helmet page. These are expensive. I guess I don't ask kids how much they're paying for their helmet, but that's a lot of money. So there's a ton of helmets on here, and you can scroll down just to see what the different costs are. I don't know if you guys like podcasts, but there's a pediatric sports medicine podcast with Mark Halstead. He's a primary care sports doc at WashU. He interviewed the gentleman who's the head of this lab, and they talk about what their testing outline is or guidelines and how they come to these decisions. And generally they recommend trying to do a 4 or 5-star rated helmet, just as a heads up.
What was his name? Sorry.
Mark Halstead. Yeah, no problem. Other protective equipment, so headgear, mixed results. I say if you want to wear a headband, go for it, but do not think you're immune to getting a concussion. So if you had the ball and you have a headache, you probably have a concussion. So we still need to address that. Protective eyewear, this is bigger now in lacrosse and things like that. This is not effective at lowering your risk of a concussion, but it does help with eye facial injuries. And then mouth guards have been shown to be effective for child and teenage level hockey. I think that is a fair recommendation to probably translate into other sports. So if you have someone who would normally maybe wear a mouth guard or it's optional, you could say, okay, well, this is what we know about mouth guards in hockey. It may be beneficial for you here too. And then some policy rule changes that we know are beneficial, as well as banning body checking in child and adolescent hockey has been shown to decrease the rate of concussions, and then limiting the number of collision practices in teen football. I get a lot of questions about neck strengthening as well, which you guys probably do too. I feel like neck strengthening alone, based off of what I read, the results seem sort of mixed. But they did do a neuromuscular training program that included cervical strengthening for rugby players. And as long as they did it 3 or more times a week, that did seem to be beneficial at reducing their concussion risk. So I think if someone's asking you, do I need to do a bunch of neck extension exercises? Is that going to prevent me from getting a concussion? The answer is probably, I don't know. But if you do it as part of an overall injury reduction plan, that may have better benefit. So these are just the top 4 things from the first slide and kind of the take-home points. So if somebody says, how do I know if I'm going to have a prolonged recovery? You can just say, did you have a high initial symptom burden? That's probably the best one that we have. The best return to learn strategy is early return to learn, not always full force, but with accommodations. Returning athletes to activity and sport, again, earlier return to light aerobic activity is helpful. No contact activity until symptom-free. And then how can we try to prevent concussions? We just talked about that part. I think that's all I have. So if you guys have questions, I'm happy to answer.
Thank you to Dr. Gately. As I mentioned, we will do questions at the end for both Dr. Gately and Lauren. I forgot to mention at the beginning, so all of this we also record and we will send to you all, so that way you can go back through PowerPoints or resources, take a look at the talk again. Give us about 2 to 3 weeks, and then usually that's about as long as it'll take us, and we'll get it back to you. So I'm now going to introduce our next speaker. Lauren Walsh is the athletic trainer and program manager for Barrow Neurological Institute's Barrow Concussion Network in Phoenix. Her work focuses on providing injury prevention, education, post-concussion care, and tools to student athletes regardless of time, distance, and socioeconomic status. Additionally, she has a strength and conditioning, mindfulness, and performance psychology background and is recognized as a concussion qualified medical professional. Lauren graduated from NAU with a bachelor's degree in athletic training and the University of Florida with her master's in applied physiology and kinesiology. and she is anticipated to graduate from GCU in the spring of 2025 with her PhD in performance psychology. So, just a few things that Lauren has going on. She is a leader within Arizona and at the Bureau for Concussion Prevention. She is currently the vice president of the AZATA and is a passionate advocate for appropriate preventative and post-injury athletic health care. When she is not in athletic training mode, she pours her passion and joy into her two beautiful toddlers, one who is back here today and she is adorable, her husband, her cattle dog, and any outdoor adventure. I'd just like to add a side note that I made the really amazing decision in July of 2020. And if you live in Phoenix, moving here in July is a terrible decision. And then I moved here in 2020. So all great life decisions. And I put on a Facebook page for women in athletic training. I'm like, please, somebody be my friend. I have no friends. And Lauren, thank you. And Susie Squires, for those athletic trainers who also know her, were the two people that responded to me. And I'm forever thankful for that because they definitely helped me make friends here. So please welcome Lauren Walsh to the stage.
Thank you.
Thank you. Hi, just give me 1 second. I'll set up. All right, and I am a pacer, so I apologize. I'll try to stay still as much as possible. So like Becca said, I'm Lauren Walsh. I run the Barrow Concussion Network, and I'm here just to give you guys some updated content on the playbook for care and concussion management. So I don't have any financial disclosures to provide, but like you heard from Becca, there is some disclosures as far as the work that I do. Any of this animation that you're going to see in here is just our newest iteration of Barrow Brain Book, which is the state-mandated concussion education for interscholastic. So that comes out of Arizona Revised Statute 15.341. And this is what we're going to talk about. Okay, I'm going to go really, really briefly over concussion basics. And it says briefly, however, you are about to see a really great concussion definition. So here's just some facts. Now, I am trying to present the most updated content, but sometimes grabbing some of the updated content in lieu of where the research community is today and what they're choosing to study can be a little bit tricky. So one thing to point out is we are looking at 3.8 million concussions sustained annually that we know of. Okay, how many athletic trainers in person? How many PTs, OTs, strength coaches, other personnel? Okay, nice, welcome. So especially at the high school setting that has an athletic trainer, most of the time or many of the time, they're going to be treating the concussion in-house. So not all concussions are reported for these research databases. Now, 6.8, 9.6 days, that has to do with early reporting of concussion management, which is also my whole job, is to educate the community of early reporting. Now, this study is from 2016, and it was based on a collegiate setting, so please keep that in mind. 19.8 days, however, that came out of the 6th International Concussion in Sports Conference. So on average, a concussion resolves in 19.8 days. But there's a caveat to that as well. They looked at recovery across the continuum of age. So what we do know is being an adolescent actually has a longer recovery time. We don't know a ton in kids under the age of 6 to 8. The content is just, as you can imagine, a little bit more difficult. If you can't imagine, I'm happy to let you speak to my 2-year-old in the back and try to ask her symptoms. So that, just take it with a grain of salt. That is the average, but just know that that includes adults, children, and adolescents. And here's the best part. Here is the technical international definition of a concussion. No, please don't read it. I am happy to share this with you. Okay, but I did want to break it down, and I don't want to spend too much time because we have some good content to get to. So SRC is sports-related concussion. So for this, we are specifically talking about sports-related. So sometimes there's comorbidities with elderly patients that have dementia and stuff like that. So I am specifying sports-related. What we do know, which Dr. Gately told us, right, is head, neck, or body hit, especially that whiplash motion. We do know in that first 72 hours, there's some kind of metabolic cascade. some kind of metabolic dysfunction. Dr. Gately, also mentioned we can't see it on a CT or MRI. Okay? We also know that it may or may not lose consciousness or result in loss of consciousness. Only about 10% or so of all concussions actually have LOC. And this is the biggest one. There are no other reasons for the symptomology of the patient. So I've mapped out the signs and symptoms on average, okay? And this is going to be important when it comes to recovery and therapy, is we want to provide our therapy and our return to play specifically based on the symptomology that they are showing. So when I first got into athletic training, it was flat 2 weeks. There's nothing you can do, just sit in a dark room. We have come a long way. In fact, I won't even get into the computerized neurocognitive testing that we used back in the day. So we've come a long way. Now we can actually do therapy, okay? And that's pretty cool. As you can see, headache, most common. Now, the differential diagnosis of that headache that takes your guys' expertise. Dehydration, frustration, stress and anxiety from the concussion, comorbidity of neck injury or strain, or truly headache related to the concussive hit. So this right here I think is fascinating. This comes out of the National Athletic Trainers Association bridge statement that they published 2024. Thank you. I was like, it just came out. Thank you. So 2024, they created a bridge statement based off of the 6th International Concussion in Sports Conference. And what we have found is there are some precursors that can potentially predict persistent post-concussion symptom, which is the new term, formerly called prolonged post-concussion syndrome. So that's the new term because of the psychology behind using the term syndrome versus symptom. So what you're going to see in the newest concussion research, or at least from what I've seen, is a lot more focus on how do we present things from a psychological standpoint. And so this talks about basically the risks of here's what might happen that might lead you to a suspicion of persistent recovery. Of course, I always share red flag signs, right? Because often, if you're in a clinic, you're not going to see the patient until 72 hours after. If you're a sidelines athletic trainer, you will see it immediately. We also know that concussion symptoms can arise either immediately or 72 hours later, which is why that 72-hour re-eval is so important. So this is something very serious. Concussions are serious, but this stuff is the scary stuff that we want to make sure to refer immediately, okay? What's really nice is part of the fun part of my job is I get to make these little toolkits, these little keychains, so that we keep bright red flag. So we make sure that we are taking care of the athletes in the safest way possible. So coming out of the 6th International, they tried to organize recovery, organize management to really help you all, to say, hey, let's keep this systematic and organized. So they created the 11 R's of concussion management. The first is recognize, okay? The concussion definition has come a long way, a very long way. So recognize the updated definition. I'm not as concerned with this group here. You guys are great. But we've put a lot of community effort into explaining, hey, you don't even have to hit your head on the ground and you could still have a concussion. Or like you heard Dr. Gately say, is if they come in Monday morning and they're saying, hey, I don't feel great. Well, even though you were fine over the weekend, we need to think back to Thursday, Friday, Saturday. Obviously, we want to prevent concussions because we don't really know a lot about repetitive concussions and long-term effects. So if we can prevent it, yes. we have created a lot of rule changes. And actually what's really, really cool is Arizona was the leader in a lot of these rule changes. So our Arizona Interscholastic Association's Sports Medicine Advisory Committee, the SMAC, who have been led by some incredible healthcare providers in the state of Arizona, wrote policy to keep our Arizona athletes safer. And they took it to the National Federation of High School Athletic Association, and they've actually adopted it nationwide. So it's very cool that Arizona has always been on the cutting edge of player safety. Remove, that comes down, the newest guideline is the SCAT-6, that's the Sideline Concussion Assessment Tool. That is a validated and reliable instrument up to 72 hours following the concussive hit. So we want to remove it, we want to remove the player immediately. And like any good instrument, you have to perform the SCAT-6 systematically to maintain validity. Now, the SCOT-6 is brand new. So it's named 6 because it was the 6th international. But this is the Sports Concussion Office Assessment Tool. So this is now our validated tool in office after that 72-hour window, which that's a whole other hour-long presentation, which I am happy to help you through. Rest. Okay, we don't do cocoon therapy anymore. It's been years now, but if you remember that big NCAA controversy with the player being locked in an equipment room, we don't do that anymore. However, we do want to minimize any scenario in the first 48 hours where they could take a second kind of contact. Okay. After 48 hours, we do want to initiate early initiation of aerobic exercise because we found that that helps the recovery process, pending that it is below the threshold of symptom exacerbation. If you raise their symptom a little bit, it happens, then you back off, right? You let them rest for another day. But that's after 48 hours, and that's in an environment in which they're not at risk of falling, hitting their head, or making contact. Okay, so it would, for a football player, it would not look like having them go run with the cross-country team instead, because now they're running surrounded with people. For us, now I work in a hospital system, so I have to deal with all the fun legal and liability teams. We always recommend stationary bikes, because if you're on a physical bike and you get dizzy, you have that risk of falling off. So be just very aware of what you're recommending for home exercise programming. It worked out really nice. This wasn't even intentional. It like teared up and now it's tearing back down. So refer. The recommendation, especially for the athletic training community, the recommendation is if the athlete is having symptoms that are persisting for weeks, at that point, we probably need to refer to a concussion specialist. Sometimes it can be complex concussion situation. Sometimes, you know what, they just need that extra level of one-to-one rehab and care. But that is kind of the going recommendation right now. I already touched on this, right? We can build rehab based on symptomology map. We talked about 19.8. It's really interesting is that outside of that high school age group, the recovery is a little bit quicker. High school, the recovery slows down. Once we get back to the collegiate level, concussive recovery is a little bit quicker. Pro level is even quicker. And then something happens as we get into the geriatric age again. But I am not an expert on comorbidity conversation. If you do have specific questions about dementia, Alzheimer's, and comorbidity of concussion, I do know a couple excellent neuropsychiatrists that can walk you through it. So the reason you guys are here, maybe, is the return to learn, return to sports. Not everybody's going to need a return to learn protocol, okay? Everyone will need a return to sport or return to activity. Return to activity is a daily living. Okay, they only need a return to learn if they're struggling in the classroom. And then, of course, we always do return to learn before we do return to contact, because we want to make sure your brain is right before we put you into a risky situation. This is where we start to get into some we don't really know. Okay, So at what point do you retire due to concussions? We don't really know. And we strongly recommend that decision is made through a battery of views with a multidisciplinary approach. So a concussion neurologist, sports medicine physician, athletic trainer, PT, OT, speech, the athlete, the parents or their children, really come together to figure out what do we do and at what point. I do want to note that the 6th International Concussion publication is not heavy on the CTE at all, and the reason for that is because the publication is on concussions. So they specifically kept it to a concussion document, which is why the reconsider and residual is a little bit unclear because it is really an emerging area of research. So I just want to remind you again, right, these are our symptoms. Now we have personified the symptoms in our software, but these are the symptoms. If they're having emotional symptomologies, we're probably going to bring in a psychiatrist or a psychologist. When we get into the cognitive, that's going to be our speech therapist. They are excellent with that, with keeping things straight and concentration. Physical stuff, we're going to bring in our PTs, our OTs, right? Show them stretching and strengthening and recovery. And then sleep disturbances, we want sleep hygiene. And actually, Arizona and specifically Phoenix is very lucky. We have an excellent sleep neurologist and a sleep neurology program. So please don't forget about that piece. I'm not going to touch on return to learn. I'm just going to show these slides because Dr. Gately talked about it. But I do want to touch on early initiation. Okay, this is what's really struggling. Hopefully, if you're in the clinic, you don't see some of these difficulties, but we see it a lot from teachers of, well, this is ridiculous. They're acting a fool at lunch. Okay, this is ridiculous, right? Well, if you sprain your ankle, you can still have fun and be dumb and make good decisions and make bad decisions. It's just that you can't do certain tasks that aggravate your ankle. A concussion is very similar. Now we want to protect them from taking a second hit. But if they're able to do something at lunch and it's not making their symptoms worse, that's why you're going to see them doing it. Okay. So we do want to start that early initiation of aerobic exercise, but if it exacerbates their symptoms, then we just back off for the day and we reinitiate it the next day. I know that's kind of like two separate constructs in one, so I apologize for that. We make return to learn recommendations based on their symptomology map. This is right now the recommended process. And so really the return to play. So we can start the return to play progression even when they're in the return to learn progression. We just don't want to finish return to play before return to learn is done. And we don't want to bridge from non-contact to contact, or contact being risk of taking a hit or falling or something like that until return to learn is completely finished. Oops, there we go. They can do ADLs after, in that 48 hours post. They can do the early initiation. We want to avoid the concussive hits, right? We've talked about that a lot. The athletes think, well, hey, I saw this pro football player return in 7 days or something else. Take that with a grain of salt. Every concussion is different. In the words of Dr. Tamara Valovich-McLeod, if you've seen like a snowflake, if you've seen one concussion, you've seen one concussion. So that's really difficult for a lot of athletes, especially adolescents, to realize is that, yes, this is the average, but it is what it is. So what does the actual process look like? Okay. It is a 6-step process, not a 6-day process. A 6-step process. Okay. Step 2 has become a little bit confusing because it's now 2A and 2B, which we haven't historically had. And this progression has been around for at least 20 years, if not longer. Step 2 is now split off into, first we want to elevate their blood pressure and heart rate at a light level. Then we want to elevate their blood pressure and heart rate at a high level. So the research specifically, right, because they have to quantify everything, says 30% of max heart rate, and then we jump to 50% of max heart rate. Then we jump to 70% of max heart rate. That doesn't mean a lot to the patient. That might not even mean a lot to you. So what I've told athletes is, okay, here's how we're going to start. We're going to do some exercise, and I want you to be tired, but you can at least speak a sentence, maybe two, before having to catch your breath. If you can't even talk, this is too hard. And then the next step is, okay, you should be able to say yes, no. You should be exhausted, but you should be able to give me a couple words. That's the 70% range. So full contact practice, what does that look like for sports like volleyball, cross country, swimming, diving, working for some industrial programs around the valley that I will not name? That's where the creativity comes up, right? Your guys' best knowledge base is your functional exercise creation. Okay, for me, that's the most fun. I get to be as creative as I can and try to mimic activities of daily living and work requirements. So the contact piece for sports like football, basketball, that's super easy, soccer. When we get into those non-contacts, you have to get creative. So it's setting up people around them that are going to interact with them. Even in volleyball, to an extent, it is contact because they have players on either side. If you've never worked a cross-country meet or, say, one of the half marathons, definitely work it. You will see just how contact marathon running is. And then, of course, we always want to do a full contact practice on a separate day than game day, ideally. So that is the full clearance, is returning to activity. If symptoms arise at some point, we just stop, we rest for a day, and then we try it again, okay? Because that tells us something happened, okay? Did they not drink enough water, or they have an electrolyte imbalance? This is where you have to become the detective. Is it just that, okay, no, you know what? Maybe their concussion isn't fully healed. We don't know if the concussion is fully healed until we stress that part of the brain. So that's why we stress the cognitive first, and then the physical piece second. This is the best part, right? Is the timeline. Believe it or not, okay, tell your athletes, believe it or not, I want you to return to play. Believe it or not, I want you to go back to the job you love, to go back to the hobbies you love. So I do like to finish with that, and I like to finish with my reason why. Becca embarrassingly gave me a very lovely introduction. I can only do what I do because of these people on this earth for me. So, questions for both Dr. Gately and I? Yes.
I have a couple, but when I went to one now and
I would say, come on, have my back. Don't stress me out too much.
so Dr. Gately in her application mentioned if the symptoms resolve in an hour, then it'll be okay. You just mentioned if the symptoms resolve, then we shut them down, we let them rest that day, and then we continue. So if they resolve in an hour, is it okay to continue with the progression that day or the next?
So that is a great question. In learning about epistemological worldviews, you know, it comes down to what is your training? How confident do you feel? If you are not a physician who is the expert, for me, clinically, it would be, okay, well, let me discuss it with my team physician. From the other side of it, I will defer to Dr. Gately.
Sorry, I heard part of it. Oh, sorry. Let me get in front of this. You're talking about the hour mild brief symptom increase.
Right. So Lauren said to shut down if the symptoms occur.
Yes.
You mentioned if they resolve in an hour, then we're okay.
Yes.
So when is it okay to shut down, and when is it okay to continue on that day or the next?
what Lauren is describing is how we have always done it. With this new protocol that splits 2 into 2A and 2B, that's when it seems like they added the mild brief thing. So I think they're saying if it's short-lived, normally I'll tell people, like, if you have symptoms that evening into the next day, it's a no. You need to be going back. I do think, especially if you're in a non-contact step, as long as you're not going higher than those 2 points and it is less than an hour, personally, I would let it ride. But it kind of depends on the kid, too. Like, do I think they're telling me the truth or not? A little bit. But I think if you're not doing a full contact practice, that is a reasonable approach. Yeah.
And to add, there's a big difference going 0 out of 6 headache to a 1 to 2 out of 6 versus if they say, oh my God, it's a 4 and they're grabbing and crying, that could change.
Yeah. And sometimes the kids too, I've had a few soccer kids where they're like practicing by a power plant or like something very strange is happening at the same time that may contribute to. So just asking those questions.
Thank you. I believe it. You said it was on a 0 to 10 scale instead of a 0 to 6 scale. So it's a 2-point increase on a 0 to 10 scale or a 2-point?
The protocol, I think, says 0 to 10, but on the PCSS, it's a 0 to 6, which makes it really confusing.
And to make it even more difficult, the SCOT-6, the Sports Concussion Office Assessment Tool, there's a part of it where you're asking 0 to 10 and a part of it where we're asking 0 to 6. Great question. They made it really easy for us.
Yeah. I think you could say, too, is it a little worse or is it a lot worse, especially if it's a younger kid?
Yes.
Oh, question. So, like in the collegiate setting when we're trying to follow those guidelines, we tend to run into like, they might have a practice in the evening, and so we're going to do like step 2 kind of with that cognitive, so they have the psychosocial interactions, but then maybe like the next morning, they'll have like the team's practice times will change sometimes. When we're doing or trying to play, like, is it a strict, like each step or day has to be 24 hours? Or is there a little bit of like variance? Like, is it safe to fluctuate? Like, okay, we did last night at like 2A and tomorrow morning we'll try 2B, or is that not? Like, is that too little time or?
Yeah, great question. So the question for those online is that at the collegiate setting, although in a lot of the different settings, is say one day you have an evening practice and then the next day you have a morning practice. Does it have to be 24 hours between steps? From my viewpoint, right, and like Karen pointed out, is we have different epistemological worldviews, is that it depends, right, which is the worst answer. It depends, which is why your guys' expertise is so important, is it depends. If they breeze through it on the evening, so first of all, steps do not equate to 24-hour days. They don't. They can, but they don't. As an athletic trainer, especially at the collegiate level or the high school level, also you want to rope in your team physician and what they believe. So if they breeze through step 2 on the evening before and they're having absolutely no issues, they feel great, the next morning they feel great, that might be a judgment call where I go ahead and progress them. So it depends.
Yeah, I think if you're anywhere below a full contact practice, I would let it go personally. So if you're going like step 2 to step 3 and they're only like 15 hours apart and you felt fine the whole time, go for it. Let's see what happens a little bit. But if you're going non-contact practice, full contact practice, or full practice gain, then I would probably be a little bit more hesitant. And really, like, the way I kind of describe the protocol to families is like, or athletes, each day is meant to be harder and longer than the day before it to see if your symptoms are going to come back. So again, I don't really say like, let's set that 24-hour timer and go, but as long as it's spaced out, I'm okay with it.
What's like a minimum probably between the steps if you less time to work it?
A night should pass, I would say, personally.
I'll say, because I only know the old recommendations and it might scare some people in here. So, sorry, that question was, what was the minimum progression between the steps?
And again, I think it's variable too. Like, sometimes we'll have like a senior who's not going to play in college. It's their last game ever. They've been symptom free for 3 weeks, but they just didn't see us in time. the reality is, like, I'm probably going to let you play if you've done some sort of activity, because I think it's important in general, and I think your risk is low that you're all of a sudden going to go out and feel terrible, as long as you've done something leading up to it. So it's kind of situation dependent too.
Question. Dr. Gately, this is for you. You mentioned a history of migraine in females increases concussion risk. Is there a similar correlation for males, or is it just less? So is that prevalent?
Increases your risk for persistent symptoms. I don't believe the same correlation exists for males as far as I know. I feel like the data is a little bit mixed on migraines and learning disabilities and things like that in general. Anecdotally, I feel that females with mental health diagnoses tend to have prolonged recoveries compared to those who have a history of migraines. And I think with the migraine part too, it can get, sorry, I'm going off on a tangent, but it can get confusing because they'll say, well, yes, I'm still having headaches. Okay, but are these your normal headaches? Are these new headaches? All of those kinds of things to differentiate.
Speaking of the headaches, everything, I had a patient who actually had like a lot of headaches, and I'm a PTA, and I had a couple of PTs who had different ways of treating that. One of them would be like, okay, stop the activity and just rest for a little bit, and then, you know, in a couple hours, see if it exasperates again. Another PT would be like, okay, just take some acetaminophen. So is there like a recommendation on like how we would have them manage a headache, or is it just something they should kind of just try to rest and ride out?
Yes, that's a really good question.
Do you want me to take that one?
Yeah, you can go. I'll think about it.
So the question was, you have a patient who who is doing therapy, and their therapy exacerbates their headache. Do you let them ride it out and see what happens, or do you allow some kind of headache pain reliever? So that's a little bit difficult. It depends on where they're at in rehab and where they're at in therapy and the return to play protocol. So we are not going to start the return to play protocol. And by that, I specifically mean we are not going to get into the 6 days. People have started to call protocol just the whole from impact to return to game. They call that the protocol. But in this case, it's the 6 steps. We are not going to start that until they are symptom-free with no pain management or any kind of intervention, pharmaceutical intervention. As far as the clinical in the moment, you know what, we already know this kid's probably not going to start this for a week. It would come down to a lot of components. It would depend. If they want to rest, recover, they're feeling a little bit better, they do want to get through some movements and motion, I might say, okay, why don't we take a low dosage? But that's my viewpoint.
I mean, same thing. I guess it sort of depends. I guess the place where maybe I would differ a little is I will let you get part of the way into it when you're still symptomatic, because we know aerobic exercise is helpful. So like step 1 is like day-to-day life, walking. You should be doing those things even if you have symptoms, because we know they are helpful. Even if somebody wants to go to practice and like be a ball kid, I don't know, I'll let them do that as long as it's relatively safe, of course. So if they're kind of in the early steps of it and they have a headache, of course you should take medicine. I don't want you to be suffering for 7 hours a day or anything. But if you're close to getting cleared, you shouldn't be relying on medicine to get rid of your headache. Yeah.
Yeah. Yes.
At one point, you, Dr. Gately, said one of the barriers is lack of communication.
Yeah.
And so you want them to call me. When you said me, did you mean the team physician? Did you mean the treating physician? Did you mean all of us should be calling you?
You can call me, the school nurse can call me, the principal can call me, excuse me. I literally don't care. But what's really frustrating is when a kid comes back and they feel terrible because they haven't had a single thing printed out for them. They're taking all these tests, they're going to full days, and they feel like trash. And that's hard if the parents think like, okay, I sent what we talked about, right? What the doctor wrote, and now nothing has happened. And then they just wait for a couple weeks to come see me again. And I'm like, oh, well, we could have been feeling better had somebody reached out to me. So you can have anyone call me. I'm happy to chat. Yeah.
Brittany. Okay. Yes.
Well, first of all, so the Dr. GP talked clinic during your presentation about affix-seeking melatonin. So is there somebody who is already on melatonin prior to getting the concussion and then it sustained a concussion? Did we ask them to continue their normal dose for sleep hygiene? Do we ask them to not take it for sleep hygiene? Kind of what are those recommendations of like specifically for melatonin?
Yeah.
Once.
And this isn't evidence-based. This would be my personal approach to it. If you're already on it, I would say continue it, especially if you're having difficulty falling asleep. I would not change their dose, but I would make sure they're taking it at the right time. So sometimes kids will take it like 15 minutes before they want to be asleep, and that is not going to work. So it's got to be closer to like that hour before, whatever it may be. And I think one of the hard parts, and this is a different can of worms, but when we talk about like prescription medication for headache management and things like that, there are so many opportunities for improvement in their sleep hygiene, screen hygiene, all that kind of stuff, that I'm not an early prescriber of medicine, like amitriptylines, nortriptylines, things like that, just because I feel like kids have a hard time following what we talk about initially, and then to put them on an antidepressant and hope they follow that is sort of a tough thing to balance for me.
I do want to run a tangent off of the screen thing, because this is really huge that was not really applicable in my presentation, but I'm glad you said something. Screen hygiene does not mean no screens. Okay, we tried that. We being sports medicine, right, as a whole. We tried that. And what we found was actually, and I'm saying we more anecdotally, so please, if you are my methodologist, don't watch this part. What we found was concussions were taking even longer because all of a sudden, those emotional symptoms, those anxiety symptoms, that stress of not having access to their phone and their notifications and their social media was just putting them through the roof. So that was great, because I just wanted to say screen hygiene is not the same as no screen.
And can I make one comment?
Please.
Sorry, then. With the screens, too, a lot of kids will watch, like, shows, movies on their phone. And that is one thing I specifically ask about. So I'll say, I don't want you watching a full-length feature film on your phone this far away from your face, right? Like, you can watch something, but at least put it on a big screen farther away from you, and that's probably going to help us a bit. So just if they tell you, like, yeah, I'm on my phone, well, what are you doing on it exactly? Texting your friends, of course, is fine. A little social media is fine, but we want to limit the prolonged periods of use.
Have you seen how in the use of phones or everything else, have you seen any like research or thing related to like putting it night loads and changing up the light? Have you seen if that's had any effect? Because I sometimes also suggest that to my athletes if they are getting higher symptoms with certain things on their computer, I'll tell them to switch it to night mode. So they're getting rid of some of that blue light. Have you guys seen the results of that or no?
So great question. So the question was, especially regarding phones, have you noticed a difference putting it on night mode or blue light emitting mode? I am not, this is not my area of expertise, but what I am starting to learn is there's a huge wave of a certain red wave that actually will not exacerbate symptoms. I don't know that red wavelength. I apologize. I'm not even going to try and speculate. So what we're starting to see is therapists putting athletes into rose-colored glasses. There are now screens that can go over your monitors at work in that red wavelength. I am sure there is a film coming out on the phone. Your specific question, I will defer.
Yeah, I'm not sure about research specifically related to night mode or things like that. There was a few years ago, actually a patient told me about it, something called Flux. It's F.LUX, and it is basically like a built-in blue light blocker, but it's an app on your phone. So probably similar to night mode. A lot of them have already talked to their friends, so they're already on night mode by the time I finally talk to them. But we want to make sure, again, at the end of the whole thing, can you look at a normal screen without getting a headache? Yeah.
Yes.
We specialize with first responders who have significant circadian rhythm issues.
Yeah.
In adults, at least, but major research shows that the duration between when the blue light consumption stops in bed has much more impact than any other form.
Interesting.
But even the quantity throughout the day has less impact as long as the duration between when they stop and when they go to bed.
Yeah, Is that duration about an hour? Because that's generally what we tell them.
Ideally 3.
Yeah.
3, okay.
So, so the comment was that this individual works with, I apologize, for emergency responders. Okay, emergency responders, and they have a different circadian rhythm because of their job. And so what they have found is just in general, it's very important to be cognizant of when you start to do blue light blocking to help with that circadian rhythm. I have not read research firsthand. I have listened to presentations by researchers, also by researchers with a commercial bias because they sell the product, in which there are companies that are investing money into different levels of blue blocking and creating their prescription of like, okay, you put this pair on at the 3-hour mark. Ideally at the 2 to 1 hour or 3 hour mark, you turn off screens, but definitely at that 3-hour mark, their product is, okay, you put this one on and it helps with that circadian rhythm. It helps with slipping into REM and the deep cycles.
Okay, well, there's one last question.
And can you email us that article? Thank you.
Please.
Get the resources on screen sleep hygiene that you'd be willing to share that we can help with in our education to whatever audiences for it.
Absolutely.
I don't have a specific like website or anything. It's all built into our end of visit and what we discuss. But if I come across anything, of course, it sounds like Lauren has some though.
So we have very brief, but there's a fantastic sleep neurologist locally in Phoenix, and she has an extensive amount. So if you guys, since mine is handily on the screen, if you want to email me, if you're okay with it, I would be happy to reach out to you as well as reach out to some of the other professionals around the Valley. Somebody told me, actually I think it was Dr. Cardenas, that said you don't need to know everything. You just need to be willing to find somebody that knows the answers.
So they'll give them a round of applause. Thank you.